So this is an important conversation, especially for all of those folks who have recurrent pregnancy loss. There's Trisha. So I'm going to add Trisha. She is going to, where's Trisha? I have to add, I can see she joined. So Trisha is a genetic counselor. Here we go. Hello.
Hi.
How are you?
Good. How are you doing?
I'm great. You're so loud in my earbuds. I'm going to turn them down. You have perfect TV voice. Nice and projecting. Perfect. Yes. Awesome.
Wonderful.
So this, first I want to kind of back up a second, even before we introduce the company that you work with and all that. But I'd love to hear your path, because I think when it comes to genetics, it's like a black box conversation where people are like, oh, I kind of know what that is because of 23andMe. But what was your path into becoming a genetic counselor in the first place? And what does a genetic counselor really even do?
So I kind of really always loved science. Like, I just grew up. That was one of my favorite things to learn about. I took every science class I could that was offered by my high school.
That's awesome.
And I lived next door to my pediatrician, and Dr. Hiltz, I don't know. And she asked, and she knew I loved science. And so she said, do you want to come work and do some like volunteer hours at my office, and I can take you on rounds with me?
Wow.
And I was like, this is sure.
Amazing.
So I kind of got introduced to the field of medicine, probably at about 14, 15 years old. Did a lot of volunteer work through Candy Striper at the hospital and all that kind of stuff. So I actually was pre-med, and I went to school, and this was a while ago. And so the major that I picked was microbiology, and it was kind of like a pre-med track.
Okay.
And in that first biology class, we had a section on genetics, and I just thought it was
Wow.
like, it was
fascinating. You knew it was the future, right? You just knew it was the future. And it's something that I feel like what we constantly say, and I see some questions coming in, so you guys know we're going to get to them. I just want to make sure you also get the right background about Trisha and what her company offers. But I do want to say this, we kind of always remind our users and our community that genetics is not a life sentence.
No.
So can you help us get like that framework? Because especially with those of us in the reproductive field that are trying to conceive and run into struggles, we sometimes feel like, well, something's wrong with me. And if there is an underlying genetic condition, we feel like there's no hope.
The hard thing with genetics is that we still don't know a lot about it. It's still a field. I've been a genetic counselor for 17 years. I've been studying genetics since I was in college and then graduate school. And I'll just say what we knew 20 years ago is we're light years from that.
Right.
But it's almost it was like, once we sequence the genome, we're going to know everything there is to know. And it really just brought up more questions than answers.
So true.
Because there's a play of genetics and environment. And so, in terms of the most genetics, outside of genetic disease, like cystic fibrosis or Down syndrome or things like that, most things in genetics are multifactorial. So there's a bit of genetics, a bit of an environment, a bit of just other things that you may or not be able to adjust in your life that can affect the way the genetics works. And so, by altering different, becoming a more natural, lifestyle, or, kind of using sort of natural or holistic things can sometimes help. Sometimes adjusting, your own personal health, how that plays into genetics is fantastic. Whether you're, the different type of exercises you can do, how healthy, for me, for example, I can exercise all I want, but unless I take my thyroid medication, I ain't losing any weight. So a lot of it is the same thing with genetics too, is like how, the different things that we can do in combination together can have an effect. So it's not a life sentence. There's, there are things, when we talk about specific genetic abnormalities and genetic syndromes. Currently, I'm working with a group where we're physically doing gene therapy type things and really treating genetic disease with like, it's amazing that the things that we're doing now were only dreamt of. And it was like kind of one day, we'll be able to do this, and thinking it would be, 50 years from now. And it really was just 10 years down the road.
It's amazing.
Yeah, it's the
I
amount
have chills because I have chills about that. I just read an article about using CRISPR to cure sickle cell.
Yeah.
I mean, yeah, the science in this field is just unbelievable, but still a lot of us don't know some of the basics. And there's a couple questions already come in. So let's jump to these questions, and then I'll go back to some more kind of broad stroke stuff, everybody. So hang in there, for us. IVF got a dream. She and her husband carry Usher's type 2. Of their 5 blasts, none were impacted fully. 2 were carriers like she is, but none were full-blown Ushers. We were told 25% would still have it, that there's still a 1 in 4 chance. So they have 5 blasts, so 1 in 4 chance that even though they're just carriers, that they still might have Ushers.
I don't know if that's a misunderstanding in the sense of, if they're doing pre-implantation genetic diagnosis, that is, we always recommend that it's followed up by diagnosis in pregnancy via invasive testing like chorionic villus sampling and amniocentesis. So that may be what her physicians are referring to, is that, we've tested it. It most likely is a carrier,
right?
But we need to confirm that in the, by prenatal testing. That seems to me probably what the physicians might be referring to, is that PGD, it significantly increases the likelihood that you're implanting a normal or a carrier embryo, but there's still not a 100% chance we got this right, because that's just the limitation of PGD. So doing a confirmatory diagnostic test in pregnancy is able to kind of reduce and kind of verify that the PGD worked.
So here, and just so that everybody understands what we're talking about, even with PGD and PGT, is that there's 2 types of genetic testing on embryos. One is more of a screening panel just to make sure that the chromosomes are normal. And, that can tell you about Down syndrome, trisomies, things that lead to miscarriage. What this audience member, IVF Got a Dream, she and her husband used they had to have a custom test to hand select which embryos are unaffected. And you can do that diagnosis type of testing for things like ruling out BRCA, genetic mutations, or cystic fibrosis. And it's usually there's a dominant single gene that we're trying to test for, correct? Although they're now recognizing that there's more than one gene involved, even in these, what we first thought were single gene diseases, correct?
Yeah, it's, like I said, you think we're gonna know everything, and it's just wow, we really, and that's kind of, why it's important before you go through processes like IVF, is to do the testing to make sure that you're not going through this process to only find out that you're both carriers of a genetic condition, that you can significantly reduce the likelihood of having a pregnancy that's affected. So
good point. Right. Yeah. That's a good point. Okay. Molly's coming in with, are trisomies totally random, or could an abnormal parental karyotype cause it?
So 2 things. So if it's a trisomy, all right, we're going to go back to basic biology for just a second. All right. My daughter's learning this in 7th grade. So good.
I think we have to keep learning it over and over.
It is. So we all have 46 chromosomes. That's a normal chromosome complement or karyotype. They all come in pairs. So we have 46 individual chromosomes, but we have 2 copies of every numbered chromosome, 22 pairs. 1 we've inherited of each pair from our mom, and 1 of each pair we've inherited from our dad. And the last pair determines sex. So 2 X's would be a girl, X and a Y, a boy. Okay. A trisomy, if you break down that word, trisomy, tri refers to 3, somy referring to chromosome. So you're talking about 3 chromosome, of a certain pair. For example, Down syndrome. The fancy medical name for Down syndrome is trisomy 21, meaning instead of the 2 normal copies of 21, you have 3. With that said, there can, and 98% of babies with Down syndrome have 3 separate chromosome 21s. Whenever you have a complete extra copy of a chromosome, that is an error in the development of an egg or a sperm that is by no means genetic or inherited, meaning the parents themselves have 46 chromosomes, but in the creation of the egg or that sperm, term meiosis, if you remember that one, throw you back. There's that separation of chromosomes to create didn't happen correctly. So those chromosomes travel to the same egg or sperm. So that's an accident in the formation of an egg or sperm. It can happen no matter how old moms are. And we do know that nothing, and how young, whether you're 20, 30, or 40, it can happen. Just the actual chance of it happening changes, but it most often is happening with nothing that moms or dads did or did not do that can cause that to happen. It's a complete accident of nature. In less than 2% of babies with Down syndrome, there's a structural rearrangement that the parents can carry, that the 21 is attached to a different chromosome. So they're kind of, the overall complement is 47. However, the structural, when you look at the actual karyotype, they're attached. So that's a translocation. A translocation can be inherited from a carrier mother or a carrier father. And that's why it's important in couples who have recurrent pregnancy loss is to rule out in both the mother and the father if they have a structural chromosome rearrangement that can lead to an imbalanced egg or sperm, and therefore zygote, because that significantly increases the risk of pregnancy loss.
Okay, got it. So if somebody has, if they do have recurrent pregnancy loss, that is one of the things genetically you would test for.
Yes. So anytime a couple, the guidelines have shifted a little bit, but if anytime a couple has had 2 miscarriages back to back or 3 miscarriages overall, both partners. So I know doctors usually go to test moms and then we forget about dads. Dads are very important in this scenario because the gender doesn't matter here. So we need to test both mom and dad to make sure that their karyotype, their chromosomes are 46, whether it's XX or XY, and that the structure of each chromosome is correct and normally formed.
Okay. Now, what else genetically do you look at when it comes to recurrent pregnancy loss?
There are some forms of when moms might have different types of disorders involving her hormones. Sometimes we can have, where she might have 46XXX or 46X. They can be a mosaic Turner syndrome, where they have some, like anything involving hormone, like if it affects the gene, affects the organ producing the hormone, or affects the pathway of a certain hormone being produced, that can be inherited, but it's usually, most genetic causes are in the terms for recurrent pregnancy loss are in the structural rearrangement or a parental chromosome abnormality.
And how is that test conducted? Is it saliva, like 23andMe, or is it blood?
Most of the time we prefer blood for that particular test because you want to get a high resolution chromosome analysis. So chromosomes have banding patterns. So which is how someone much smarter than me can look at all these little squiggly lines on a slide in a cell and be able to say that the different banding pattern, that means that this is a chromosome number 1. And they know, and it's fascinating to watch them. I worked in the lab for a little bit and saw them do it. They challenged me. I failed miserably, but to put,
it sounds amazing. It sounds very hard.
Yeah. It is, but the way that the banding pattern is in each chromosome is very specific. And so it's kind of like reading a book. Like if you're reading a book, you can tell like when sentences are out of order. They use the banding pattern to see are the sentences in order. And if they're not in order, that can interfere with the way that gametes inherit genetic information in a balanced chromosome complement. And so, we just I was telling you a little bit, I guess, yesterday, we had a patient who's had 8 pregnancies, 2 healthy, normal children, and they were on their 6th pregnancy loss. So they were referred to us. And we tested both mom and dad, and dad had one of these chromosome rearrangements where the sentences were out of order. Wow. So something in one of his chromosomes was flipped, and then that equaled some unbalanced chromosome, sperm with unbalanced chromosome information, which caused the recurrent miscarriages. So we want to make sure
the path for them going to be IVF with PGT.
Yeah, so it'll be PG, so they'll have to look at the carry. This isn't something, unless, they're doing studies now on the microarray to see where the breakpoints are, if it's something that can easily be fished, like a PGD type screening, or if they're going to have to do a full karyotype.
Okay, got it. Okay, this is so fascinating. And wouldn't it be great if they could just look at a sperm under a microscope and tell if it's balanced translocation? Maybe there's like a particular shape of the tail that is. I
don't rule out anything in the future.
Yeah,
in terms of what they're going to be capable to do.
Right. That would solve everything, right? You just do one egg retrieval, and you just need the one healthy sperm that doesn't have it.
Yeah, that would be good.
So in that particular case with someone like him, logical question, I don't know if anybody else is thinking this, but does it impact, to my point, does it impact 100% of his sperm output, or does it only impact some, and that's why they have 2 healthy children?
Yeah, it only impacts some. Like I said, remember they have 2 copies of every chromosome.
Right.
One of his chromosomes was normal, and one of his chromosomes had this change.
Got it.
So if the embryo received his normal chromosome,
it'd be fine.
Right. And we don't know that every miscarriage was related to that, because we know pregnancies can miscarry even if they have a normal chromosome complement. Right. But that definitely increases the likelihood that would occur.
And is there anything with that kind of genetic condition, he can't change the fact that he has that particular situation. So there's not really anything for him to do environmentally or through antioxidants or anything else. Yeah.
No. So, in that case, we talk to couples about sperm donor. We talk to them, like to avoid going through like a PGD or PGT or however it would have to happen for them. And I leave that to the determination for what that is usually the REI guys.
Yeah. Right.
But they, in terms of the, like what's available to them, same thing. If this were the woman, you can talk about egg donor, and that kind of thing, terms of pre-pregnancy. And, after you're pregnant, you can always look at a fetal chromosome complement by diagnostic testing as well.
I imagine that if I was getting that report in my email box, I'd be very confused and overwhelmed and not really understanding what any of it meant, let alone knowing what's next. So how does that conversation go with you? Like, did you put both, are you, especially in this virtual environment, is it a Zoom call where you were on with the couple? Okay. And did you counsel them before they did the testing and then after the testing as well?
That's an important piece, which most of the time is the reason why they refer you to genetics or to a genetic counselor before they do just randomly start doing that test.
Right.
Is because we go through the the different reasons why pregnancies miscarry, and some of them are not genetic. Some of them are uterine abnormalities. Some of them, like just, antibodies, if a woman
Sure.
has a Kel antibody or, all these different things. And, so a lot of the OBs, they take care of a good portion of the testing, the antiphospholipid stuff, all that, they're really doing that. But they're saying because of some of the results that we might get, I don't feel comfortable disclosing that to my patient.
Right.
So because they don't understand it either. So they send patients to us, and we from even before they have the test, we explain what the test is, what it's testing for, what it says when it's normal, what it says, what it could mean if it's abnormal, the different types of translocations that can occur.
Right.
And so when we call them with results, they already have, because you only really pick up about a little bit on that. So when you call back, you reiterate all of those things in the context of what their results are. So they've heard it before. It helps them. They haven't not had a biology conversation since high school type thing.
Sure. Yeah, that makes sense. Okay. Sandoval's asking a question, or has a concern that I'm not sure that we can answer. But I think that we might need to point her to call her doctor who's prescribing Clomid. She's currently on a 6-month Clomid treatment, but she started bleeding yesterday and today it stopped. She's feeling worried. And whenever we see that, we say, pick up the phone and call your doctor right away. Call the nurse line. If you're worried, just call.
Absolutely. Anytime. I've worked in OB practices. I've worked with maternal fetal medicine physicians. I've worked with the reproductive endocrinologists. They want to hear from you if you have that type of concern, so that they can discuss with you. They don't want it to be something that you're worried about in your brain. They want you to express it so that they can help you as soon as possible.
Exactly.
So please reach out to your OB, your gynecologist, anyone who's treating you, to answer your question.
Thank you, Trisha. So, there are a couple of different methods now for genetic testing of embryos. And don't forget, everybody, you can ask questions. I know we're throwing a lot of Bio 101 at you right now. And Trisha, you're doing a great job making it not overwhelming. When it comes to this, though, this is a great question. Brown Girl Infertility. Thoughts on PGT tested normal embryos that are low grade?
So from my understanding, and this is kind of where I always reference back to the REI guys, because they know the grades of embryos and how important that is and what the different success rates and everything like that. My answer to that question would be, I can't explain why some embryos that are low grade would become a healthy pregnancy. And I don't understand why some wouldn't. Just like in normal pregnancy, I don't know why some women have some complications and others don't. So I think that that's an important question for the REI person who received the report, as to what, because every lab will tell different things about what made it low grade. That's
the confusing, and that's the real controversy around grading. So I will tell you from Dr. Chen's perspective, Serena, who I do Monday Motivations with every week, she's an REI, and my business partner happens to be a reproductive embryologist who invented genetic testing of embryos. So you're in good hands, okay, for asking the question. PGT trumps embryo grading. So embryo grading is considered a subjective measurement, and there's lots of different ways to do embryo grading. It could, the low grade might just have been that it took a long time to grow to blast when they did the PGT, but they would, the REIs that are in our network do advocate for PGT kind of trumping that embryo grading. Yeah. So that if you have a normal, great, put the normal in, let's give it a shot. Right. So, that's kind of the important thing to keep in mind is don't get hung up on the grading system, because there's so much controversy around it.
Yeah. That's why I go to go to your physician who has all of that information available to them about why it was graded the way that it was. But I agree, PGT would trump.
Yes.
That's a great thing for the PGT to be normal.
Yeah, it's a great thing. So you should have a lot of hope actually about that.
Yeah. Mm-hmm.
Yep. So we have some other questions coming in too. So just when I went to do my first frozen embryo transfer, I did PGT on all my embryos, and I had 9 that we PGT'd, 2 that came back with trisomies and had to be discarded, and then 2 were sort of neck and neck in like their grading system, but they were both normals. 1 was fully hatched blastocyst and 1 was partially hatched. The partially hatched is my son. And I mean, I have his little picture to see like partially hatched. It looks like 2 sort of like bubbles stuck together, right? And so these embryos that I have remaining would be considered the lower grade embryos, and I have 5 left. Nobody's worried about whether or not I'm going to have another child from the 5 that are left over just because they're lower grade, because they're PGT normals. Mm-hmm. So that's kind of just another, fodder. So let's see, Pam, asking about this again, we might not be able to answer specifically, but the success rate of having a baby through IVF when you're 42 versus when you use an egg from a donor bank. So perhaps, Trisha, you could just talk to the increased rate of chromosomal abnormalities as we age, that's just a normal sort of epigenetic. Is it epigenetic changes? Is that what happens?
No, I mean, it's just, okay. We've had all of our eggs from birth, women. All of our eggs we've had since. Matter of fact, when you're carrying a female fetus, you're carrying your grandchildren, because all the female fetuses have all the eggs that they're ever going to have in their lifetime. Okay, fun fact. So our eggs are as old as we are. What they do that separation. Remember, we talked about they're going from that 46 to create the egg with 23. They're doing that the month that you become pregnant. Okay. The only thing that is associated with an increased risk of having a child with an extra chromosome, like a Down syndrome or other types of trisomies, is the age of the cell when it does its division. Okay. So at the age of 20, your chance to have a child, this would be a full term, I'll use the live birth data, with a chromosome abnormality is about 1 in 526. I mean, that's any and all chromosome abnormalities. If you separate it out, Down syndrome, it's about 1 in 1,500. Okay. As you get older, that number slightly increases. So a lot of people hear the term advanced maternal age, and it's like, dun, 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 I know. Well,
it's better than geriatric maternal age, which is what they called me. It's like the worst word ever. What dude came up with that term?
Dude would be the proper one. All right.
Yes.
So historically, they've chosen 35 as that number. And typically they chose 35 because the number at 35 goes from 34 is about 1 in 244-ish to at 35, it becomes 179. And back in the dark ages where they didn't have screening like NIPT or NIPS or all the different new cell-free DNA screening that we have, they just had they didn't even have ultrasound.
Right.
They had amniocentesis. So they kind of drew a line. They said an amnio's risk at that time was 1 in 200 because they didn't have ultrasound. So that's where the 35 kind of came from, where they drew that line. So at 34, the risk was just under 1 in 200. Didn't hear anything about it. At 35, now all of a sudden you're being offered extra testing, where the risk really numerically isn't that much different.
Isn't that much more, right?
Yeah. So at the age of 42, and I'll just use my chart, the risk is for any and all chromosome abnormalities for a 42-year-old when she is due. We go by how old you are at your due date, is about 1 in 39. So that means if I have 39 women in a room, all of them will be 42, only one, translated to about 3%. So that's still 97% of moms who are 42, their babies will not have a chromosome abnormality at live birth. Okay.
Yep. Got it.
So
that's important.
So it's still not, doom and gloom, but still 97%, right? So the odds are always in your favor as you get older. However, if you look at the eggs, that's at live birth. If you look at eggs at the time in your first trimester, that risk is higher. So when you talk about success in IVF and PGT in terms of screening for Down syndrome and chromosome abnormalities, you're going to have a lot more abnormal embryos than you would if you were using a donor egg. So just because the likelihood of them having an extra chromosome abnormality is lower in the beginning. So there's always, even 42, the greatest likelihood is baby will not have a chromosome abnormality. But if you're in the process of IVF and you're going through all of this, you might want to consider a donor egg if that's something that if you've been trying with your own embryos and it hasn't been successful, that might be something that can help is a donor egg.
Right. And I think it's important to keep in mind that there are lots of 42-year-olds who are successful with IVF, with PGT, and that there's so many things that go into it, including how many eggs she has left. So how, what does the stimulation cycle look like? Can she, only takes one, genetically normal, only takes one. And the cool thing is at 42, I'm 44, about to do my second frozen embryo transfer next year. And, the great thing is it doesn't matter what age our uterus is. There's the uterus doesn't have the same aging process that our eggs do. So we don't worry so much about that. I think that the most important thing, Pam, when I'm talking to patients who are kind of trying to consider their own eggs versus donor eggs is how many tries can your heart handle? How many failures can you handle? What can your pocketbook handle in terms of financial access? Because if you're open to all the options, I think you have to weigh the pros and cons of both. And it's still, for all ages, on average, takes 3 cycles to achieve success. Sometimes people who are over 40 will do back-to-back egg retrievals and then go to take the entire cohort, make embryos, do the PGT. So they have kind of just, better numbers to work with, to do one frozen embryo transfer with a genetically normal. So I'm happy to chat with you even more kind of about that decision-making process, Pam. It's a tough one, but I have lots of friends and lots of community members who are moms through egg donation. We love the women who have donated their eggs. Somebody on my team is an egg donor. My son is donor conceived, and it's been a wonderful journey with him to be 7. And I had an anonymous sperm donor, and it's been kind of a mystery unfolding, actually getting to know him throughout his life, and we're very open about it. We always talk about did this come from you, mama, or did this come from the donor? And he's sort of always kind of assuming, oh, well, that must've been the sperm donor, so we're super open about it, me and my son, Pam. So just happy to talk with you further offline, about that. But I think these are such incredibly important, compelling questions, because we see people even in their 30s who have gone through 7 rounds of IVF, 10 rounds of IVF. And, I don't want people heading into it thinking that has to be the case for them, but everybody needs to know how many they have in them, before they get started. Because we know that the success rates cumulatively are incredibly high if they stick with it. But sometimes emotionally and mentally and financially, that's hard. I mean, it gets me choked up because so many people have been through so much that if ultimately the most important thing is the mother-child relationship to someone, I just want them to get to that as fast as possible. And some people have to exhaust all their biological options first before they're comfortable, and then they have to know, well, what does exhaust all my options look like for me? Does that mean 3 cycles? Does that mean 4? Does it mean 1, So these are tough decisions.
And I have a very close family member who was young, and they kind of knew that they would have to do an IVF cycle, in order to conceive. But she was young, she was healthy. And then she just didn't, when they started giving her the shots, it was like, you're not reacting like a normal, 30-year-old
Oh,
would at this point in
wow.
time. So it's, and
Yeah.
they have their one son and they tried to go for another and it wasn't working. And it, just like you said, it was kind of the hard decision of,
Yeah.
how much can we take and kind of where are we? So it's
Right.
it's a personal path. And that's why, always reach out to people who are available to you to kind of help you maybe see, is this an option for me?
And I'll say too, when we're in our 40s, and this is important for all of us, no matter what our age is, if IVF is the path, the lab really matters. I mean, we're having a genetic conversation here. Like, no matter how much you love your doctor or the personality of your doctor, really the lab makes a giant, giant difference. And
Huge.
So, yeah. And so, you want to make sure that you're with an amazing lab. We'll just leave it at that. So Brandy I'm reading through Brandy. Okay. We've got some things that Brandy's dealing with. She has a cyst on her ovaries. Does birth control mess you up from getting pregnant? So no, I mean, it prevents pregnancy until you're off, but no, it's a common misconception that birth control causes infertility, and it's just not accurate. And for those who are prone to cysts, hormonal fluctuations can definitely exacerbate them. So Dr. Chen, would certainly want to know how big your cyst is, if it needs to be removed. And REI definitely should have a conversation with you, Brandy, because we don't want it to burst. That can be very painful. Her other question is, should her partner get his sperm tested to see if he is low? 100% of the time, the answer is always yes. There's never a time where we're like, oh, no, the guy shouldn't get tested. Anytime that you're struggling to conceive, we're like, he should get tested first. But he should do it first
easiest.
because he's the easiest, he's the fastest, and it's the cheapest. I mean, and it rules out like 40% of the equation. So for sure, everybody make sure that and there's all these at-home collection kits now to make it super easy. So, Brandy, a lot of cysts, though, they come and go. If you can have cysts on your ovaries, that does not mean that you're polycystic ovary syndrome, but it also could be an indicator that you have polycystic ovary syndrome, but they can come and go. So I just think that you probably would benefit from having an REI consult, and we can help you with that, Brandy. If you just DM us, we can find you somebody in your area. Yeah, no problem. Sandoval.
I would definitely, I second that.
5 minutes. Good.
Because my bill was just an hour ago.
Oh, I know. That's my son asking when we're going to be done. He's always my timekeeper. He's like, how many more minutes do you have? And then he comes back and he tells everybody, like, it's supposed to be over now. So Sandoval asking, do you think you can't get pregnant? Do you think if you can't get pregnant within 4 years of trying, our partner needs to do a sperm? Sandoval, I would have said if you hadn't gotten pregnant within 6 months, like, get tested. I see, and you're not alone, Sandoval. I see this over and over and over again, and it frustrates me because I feel like in the medical system, we're not treating people in the generalized healthcare system for infertility properly. She should not be going 4 years, and nobody's brought up the fact that maybe the guy needs to get his sperm tested.
Yeah. Exactly.
I mean, these are the things, like, this is why we do what we do on Fertility Answers, because, I don't want you to struggle getting pregnant for 4 years because you had the idea of getting pregnant 4 years ago. That means within that year time frame, if you're under the age of 35 and it didn't happen, we got to get you in for some diagnostics. We have to know what's going on so that you can be proactive. Some solutions are really easy, like with men, and men can clean up their lifestyle a lot of the times, and they can pump themselves full of like really good male prenatals and antioxidants. They can work with our naturopath, Dr. Raquel, on detoxing heavy metals. There's so many things on the male side that they can do. And within 3.5 months, have a full, fresh, brand new sperm, washout to see if they've had positive impact. So on the male side of things, definitely, ladies, let's get those guys testing for sure. So, All right, Rocky, let's see. From all this knowledge over the years in the field, what are the recommendations for all things to do for recurrent loss? She's getting a lot of different opinions, and it's true. And
Yes.
I've been trying to help navigate getting some different options. We have like an amazing microbiome testing partner with a new test and solution coming out that has proven to be super helpful for people who have unexplained infertility. So it is, and here's the other kind of confusing thing is that there's a lot of us who've had multiple chemical pregnancy losses, Trisha, that the clinical community doesn't really treat us the same as like recurrent pregnancy loss.
Yeah. Anytime you have recurrent pregnancy loss, if you're coming to me, we would do high resolution chromosome analysis and recommend ultrasound to look at your structure of your uterus. Do we know why those pregnancies were lost? For example, did you do any genetic testing on those embryos, such as look at the fetal karyotype? The other types of things that you want to do are look for antibodies, your antiphospholipids. How is mom? Does she have a coagulation disorder? Those are all things that OBs, most of the times, most labs actually have a panel that you can just check box and order for OBs.
And they'll get all of it. Yeah.
And they'll do that. I think so, structural, look at your uterus, do a chromosome analysis on both you and a partner. You can always do, if you are getting pregnant, so this is where you have recurrent pregnancy loss, you're able to establish a pregnancy, then that's different than having a chemical pregnancy loss, which is different than not being able to even become pregnant. So like you're never able to conceive. So I think most times if you are coming and you've had multiple chemical losses, we can treat you the same way and do the same type of genetic testing that we could do for a patient who has achieved whether it be a 5 or 6 or some early type of pregnancy. And so we do know that if you look at miscarriages in the first trimester, 50% of them are due to a chromosome abnormality. So that's not something, unless they're the specific type of chromosome abnormality, like my patient who has the spelling error in his chromosomes, most of those are going to be a random thing. So, and that's where knowing and doing a chromosome test on a miscarriage helps know going forward in a future pregnancy. For example, if you did a fetal chromosome analysis on a pregnancy that miscarried and it was determined to have trisomy 16, I know 100% of fetuses with a trisomy 16 will miscarry in the first trimester. They don't make it beyond 10 weeks of pregnancy, very rarely if they do. So in that case, that's reason why, it's nothing that moms or dads did or did not do. It's just, that was an accident. So that's different. That has an explanation rather than unexplained. So that's kind of where, if we have an unexplained loss, we start looking for, those other types of issues. And usually if you're going to see an REI, for infertility or recurrent pregnancy loss, they're going to do a whole panel of blood work on both you and him, and looking for hormones and all that kind of progesterone, all those different things that they can hopefully do to keep you pregnant. If that's the cerclage, sometimes it's a cervical incompetence type thing. So it's important to make sure that you're actively being seen as soon as you think you're pregnant, so that we can establish dating by ultrasound and all that kind of stuff.
I think, Trisha, what might be kind of helpful too is that if some people feel like they've gotten some testing done, but they're unsure if they got all the testing done, maybe they could book a counseling session with you to kind of review what tests they've already gotten done and see if there's some things that are missing. Because I feel like we hear that a lot too of people coming to us and saying like, well, I did all the testing. And then we find out that because they were doing it at the OBGYN level, they were actually missing like 70% of what an REI would order, but they weren't yet ready to make the commitment at the REI. And I feel like maybe a shorter counseling or shorter session with you that's more affordable, could be good to kind of review everything that they already know and then identify the stuff that they don't know.
Yeah. And that's what happened with this particular couple. They were on their 6th miscarriage. They had done a lot of different types of testing already that all kept coming back normal. And so for some reason, this one little piece didn't get done and was somebody finally kind of looked in the chart and said, wait, we don't have chromosomes on either of these partners. So that's where we step in, and now we know why. So, it's definitely something that you can always check with, make an appointment with a genetic counselor, make an appointment with, there's maternal fetal medicine physicians as well, like high risk doctors, that you can ask your OB to refer you to. They do preconception counseling as well. So that's something I know, my physician that I used to work with here in Providence, he would see couples, just to kind of go over. And if a mom has, I
had to do it. I mean, my OB asked me to because I'm old.
Well, yeah. So
she said it's medicine, she was like, look, you're 44. So I want you to get checked out by, an MFM. And I said, no problem. I'll do whatever I need to do.
I love maternal fetal. They're like an OBGYN who is like, just specialized. Their knowledge base is just insane. I love maternal fetal medicine.
Yeah, it's really great.
Those are most of the physicians I've worked with. So a maternal fetal medicine, so if you have a medical condition that you're concerned about in pregnancy, the best time to get those answers is when you're not pregnant, and to understand if there's something that, like, if you have diabetes, the best time to be figuring out how to be someone who's diabetic and pregnant is before you become pregnant, and what things you should do to minimize whatever risks come with being diabetic while pregnant. Same thing if you have high blood pressure, if you have a coagulation disorder, if you have all of those things, you really should see maternal fetal medicine and preconception. What can I do? Is there anything I can do to help make what might be a high risk pregnancy successful?
And by the way, we are all considered high risk if we're over the age of 35. So that's just another little fun fact about that advanced maternal age, which
I've gotten to the point,
but
I've gotten, and there's some things, like there are increased risks of high blood pressure issues as you get older in pregnancy, increased risk of gestational diabetes as we get older. Maternal fetal medicine doesn't mean to me, they're making sure that your health doesn't become a problem and affect the pregnancy. They're more of a proactive way to reduce risk. I know I see patients in a maternal fetal medicine clinic to talk about the testing options that they can have that look at their age-related risks. And if they do have cell-free DNA screening and they're negative, well, then that reduces what that risk to the fetus is because of maternal age, but they're still followed by their OB, just like every other pregnant patient, for preeclampsia, high blood pressure, all of those other things that can happen.
Exactly.
I was 27, healthy, having my first pregnancy, and ended up with preeclampsia at 30 while I was working in the high risk clinic. Ended up with preeclampsia and developed, it's just one of those things.
It just is. Exactly.
Yeah.
All right. Let's see. Mayan, 41 years old. Can she get pregnant?
Absolutely.
It just depends on a lot of things, though. So it's a big question. So the answer is 41-year-olds get pregnant all the time. A lot of times with assistance and sometimes without assistance. Certainly if you get a full workup, which I recommend. So, this is the thing about, age-related infertility is go in early, right? You're considering now, this is the year, you're already 41. I would do an REI consult, and I would just invite you to get all the diagnostics done, let them do a water sonogram, let them make sure your tubes are open, let them run an AMH, a full hormone panel,
Absolutely.
consider it like a fertility wellness checkup, Mayan. And this way you won't waste your time with the remaining good eggs, because every passing year we rapidly lose those eggs. So yes, you can look forward to success. Just remember that even for somebody who's only 21, there's only a 25% chance that they're going to conceive each month that they attempt without assistance. So you just want to be on the fastest path to success so that you can access those healthiest eggs.
And sometimes women in their 40s, they start thinking they're going through menopause, because just our bodies start kind of the premenopausal type things. Your periods change. You're going through all these different things. So if it's something that you're considering, talk to your OB about, where you are. They might want to do some hormone function tests, like where your hormones are, things like that, to see if there's anything that they can do. I've had several patients and friends who had infertility. I know a couple very, very well. They had 2 daughters when they were in their early 20s, never stopped trying for a third, just it never happened. But they were, okay, we have 2 daughters. It's just kind of, she's 44. All of a sudden she thought she was in menopause, and, so it's just like, why wait? Her youngest daughter was a freshman in college. It's like,
wow.
she's like, I'm starting all over. It's like, and it's just, she didn't think it was possible at that point. So it's one of these things, I think, that we only know so much. We only know, what we have a limitation in kind of being able to say, if you're 41, you can have a healthy, normal pregnancy. I can't say that to someone who's 20. So,
right. We just advocate that you get in so that you have a fertility wellness checkup. So you get everything checked out. So you know whether or not this is going to come easily. And if you've been having unprotected sex for years leading up to the moment that you'd like to get pregnant, we always recommend that you get a full REI because that is, that's exactly the situation we're trying to avoid. Lauren, chemical pregnancies, do they feel different than regular pregnancies in the early weeks? None of mine did. None of mine felt different. I knew the second I was pregnant on every single one and didn't feel different at all. Okay, we only have time for a couple more comments and questions. Maria used Clomid, got pregnant, and lost. Very sorry to hear that. Then she got pregnant without Clomid, lost again. So now let's run her through the short list of potential tests that she can do. Because she probably came on late. So let's run through those tests as a good review.
So you would like to speak to your physician about making sure that you, since you've had 2 losses back to back, whether they were with Clomid or without, I would recommend that they screen you for different things that can cause or be out of balance with pregnancy loss, such as your antiphospholipids, if you have any antibodies. And, I don't know how far pregnant you were when you miscarried each of those pregnancies, but you want to look at structure of your uterus, cervical incompetence. So that's an ultrasound that you can have. And then you can also, if you've had 2 subsequent, like back-to-back losses, both you and your partner should have chromosome testing to make sure that neither of you are a carrier of a balanced chromosome rearrangement that can lead to a embryo that has an unbalanced chromosome rearrangement, because that leads to miscarriage in most cases.
Okay, awesome. Thanks for that. So Brandy is mentioning she's having trouble hearing us. I hope it's just on your end and not with everybody else. But I'll tell you this, Brandy, if your partner has low sperm count, yes, there's going to be lots of lifestyle things that he can do to improve. Dr. Raquel would be a great person to check out on our app, on the Fertility Answers app. If you download that on iOS or Android, one of the things that impacts male sperm count that we advocate against is smoking pot. So if he's a recreational pot user, that's just something to know right away. We have a new partner that has a CBD epigenetic test coming out. So we'll do a whole conversation on epigenetics. The research that's coming out on and it's so frustrating because there's so many great CBD benefits for other areas of our health. reproductive wellness is not one of them. It just kills reproductive health. So yes, Brandy, get him tested and then pop on and do
6 and 8 weeks
a consult with Dr. Raquel, who can also look at other things like heavy metal, issues, some other environmental exposure things. But she can definitely help guide you on some lifestyle changes to help him improve his semen parameters. And Pam, I totally get it. It's hard emotionally and financially. So just reach out if you want to have a conversation. Totally here for you.
And I see Maria, I think she was the person who said she had those two, the miscarriages. She said she was 6 and 8 weeks. So that's less likely to be something cervical or uterine, and more likely to be something in the blood work, or blood work in terms of doing a genetics, the screen for both you and your partner, as well as doing all the kind of the panel of labs that they should do in women who have had recurrent pregnancy loss.
Okay, everybody, that's going to be it. Asking us anything about genetics. Trisha, thank you so much. She's available too. So we have, if you are a registered user on the Fertility Answers app, you've already been matched to a genetic counselor in your area. And you can request a consult with them through the app. They have the most affordable prices that we've ever seen in the market. In fact, their company stands by economically conscious pricing. And I just love that term so much, because they want to make this type of information personalized to you, accessible by you, because it's something that still routinely insurance doesn't tend to cover. So they have really great rates for our community. And remember, the Fertility Answers app is available on iOS and Android. So you can request a consult with Trisha or with one of her colleagues. It depends on the area. So some states require certain licensure and some states do not, but they have, I think, 48 out of 50 states covered. I'm pretty sure.
It's now, I think we're 50 out of 50 now. And even Canada.
Okay, fabulous. Okay, good. And even Canada. That's great, because we have Canadian users too. Awesome. So we love you guys. We want to keep hearing from you. Tell us what kind of content you need. Keep asking the questions, keep engaging, and we will continue to bring the experts right to you so you can get your questions answered immediately. And anything that we didn't get to today, just ask on the app and we'll be sure to answer it. Trisha, thanks so much for being with us. You were a fantastic guest, and we should do more of these.
Thank you. We should. Right. It was great talking to you, Alice.
Good. All right. Happy holidays, everybody. See you soon.